Hello, and welcome to Persyst Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. My name is Katie Colibreeze with Persyst, and I'm here to introduce our speaker and topic for today's Persyst Grand Rounds. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their expertise and knowledge so that we can all learn and grow together. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interests. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst. Persyst is not providing any form of compensation. There will be time for questions after the talk, so please write your questions in the Q&A area. There's a button at the bottom of the Zoom window that you can use to type in your questions. We welcome, as our speaker today, Dr. Julia Jacobs. Dr. Jacobs is the director of the Alberta Children's Epilepsy Program. She's a physician scientist who's been working with children that have epilepsy for more than 15 years. For the epilepsy program, Dr. Jacobs aims to combine compassionate care for families with providing new treatment options and high-end research to understand mechanisms that lead to seizures. Dr. Jacobs came to Calgary in 2019 to lead the pediatric epilepsy program and is a professor at the University of Calgary, Canada, and adjunct professor at the University of Freiburg, Germany. Prior to joining the team in Calgary, she's been the interim director of the Department of Pediatric Neurology and Muscular Disease at the University of Medical Center Freiburg and the head of the Pediatric Epilepsy Program. Dr. Jacobs has had a close and long-standing relationship to Canada as she received her epilepsy training at the Montreal Neurological Institute at McGill University. Dr. Jacobs is involved in clinical trials of the new anti-seizure treatments, including specialized treatments for rare genetic epilepsies and cannabidiol CBD. She is also an expert in evaluating children for epilepsy surgery. A more recently developed interest is in the early identification of children that are at risk of developing epilepsy after a first seizure or traumatic brain injury. The aim of this clinic is to prevent the development of epilepsy. Dr. Jacobs is a member of the Alberta Children's Research Institute and the Hotchkiss Brain Institute. Her research focuses on advanced analysis of EEGs for children with seizures or at risk of developing epilepsy. She also works on developing new methods for the analysis of intracranial EEG and fMRI data. Dr. Jacobs' research develops new diagnostic tools for epilepsy, including the analysis of high-frequency oscillations, or HFOs, using intracranial and scalp EEG, the analysis of simultaneous EEG and functional MRI recordings to identify epilepsy networks. So I will hand it off to Dr. Jacobs. She'll explain the learning objectives for today and take us through her presentation. Thank you, Dr. Jacobs.
Well, thank you so much for the kind introduction, and I'm excited for all of you to join me today. I came up with a couple of learning objectives for today. One of them is that I want to discuss inherent pitfalls which come with intracranial EEG recordings with you, and then discuss how we can use novel methods like high-frequency oscillations or automated EEG analysis to overcome these pitfalls. And last but not least, I want to spend some time talking about what we can combine with our stereo EEG and as other recording methods to improve the spatial samplings of stereo EEG. And I have a little bit of a disclosure, but all of these disclosures will, as you will see, have nothing to do with my talk, because I won't talk about any of this work when I'm presenting here. The most important disclosure for my talk is probably that if I would want you to give you a comprehensive overview of new methods around pre-surgical investigations and stereo EEGs, I could fill a full day of talks with this. So these the presented ideas here are examples and they are not a complete representation of the literature. What are we going to talk about today? So we will start off with an introduction into stereo EEG concepts. And some of you who have experience with stereo EEG will be like, oh, I know that. But I think it's actually a really important thing to start with, because what I think we tend to do as physicians is that we want to perfectionize the methods, we want to use it all the time, and most importantly, we want to fix our patients and their problems, but this sometimes leads to us forgetting what are the core concepts and how can I actually integrate new methods into core concepts so that they are useful. That's why I want to start with this. We're also going to talk about selecting the right candidates and the right targets for your sEEG electrodes. And then we move on a little bit into the more neuroscience. Is there a way that we understand that our electrodes are actually in the right spots after we implement them? What is the extent of the epileptogenic area, and can sEEG tell us what it is? And last but not least, how can we overcome the sampling limitations of stereo EEG and hopefully have a smaller black box or the smallest possible black box when we investigate the brain? So to start off, I think it's important, and most of you will realize that it depends very much on which electrode type you use when you implant, on what you can see, what you can aim for in regard to both localization and identification of networks, and which patients can participate. I took the two extremes of electrodes here. On the left, you have a grid. On the right, you have a stereo EEG with micro contact tips at the edge, at the end. And what you can target with these two types of electrodes might be largely different. I think now more and more centers across North America and worldwide prefer stereo EEG because it's more flexible, because you can target deep targets, and because there's less direct side effects. And then when we talk about stereo EEG, there's of course long-standing roots back to Tyler Rock when he used the first methods, but nowadays we are more modern and we use 3D reconstructions and robotic placement of our electrodes most of the time. For me, the most important thing, and the first thing I always discuss, and the basis of every stereo EEG course, is you do not want to go on a fishing expedition. And to avoid going on a fishing expedition is by having a first hypothesis. Where do I think my seizures actually come from? Having an alternative hypothesis. Do I think the seizures could also come from somewhere else? A slight hint: if you do not have an alternative hypothesis, I would not know why you have to poke a stereo EEG electrode. So you really have to have one question and have an alternative question so that it's worth your investigation. Last but not least, you should have a defined aim. Finding the focus, reducing resection size, avoiding functional deficits are some of the examples. And you can summarize all of this by making sure that you have a hypothesis and you have a purpose for your investigation. As I already mentioned, that should be quite natural to do, but I think sometimes we just want to place electrodes everywhere to make sure that we're in the right place, but this might not be the right reason to do an sEEG. I wanted to highlight for you this really cool review written by Maike Zielmans, and she is a longstanding friend of mine, but I also think she is excellent in summarizing concepts and making nice figures, as you can see here. And she summarized basically how does pre-surgical workup work now from the non-invasive space to the more invasive space at the bottom. And then she also said, is this an established method? Is it an upcoming method, or is it an experimental method? And I think what I want you to take home from this slide is that we have a lot of different tests right now which can help us to understand epilepsy, some of them more and some of them less established. But there is not one test which does it all. And for every single patient, we have to make a selection which test we want to use. And in her review, she also discusses the different concepts which we use when we want to do pre-surgical investigations. This is modified from the original Rosenau-Lüders classification about the irritative zone and the seizure onset zone. As you can see, she is a lover of high frequency oscillations like me, so she defined an HFO zone. But I think the most important about it is, if you go down here, that we still don't have a final idea about which region we actually have to remove to predict post-surgical outcome 100%. And there's, of course, the question, what is the epileptogenic zone? Is it a theoretical concept, or will there ever be something where we can actually measure it? And if you look at this table here from the same review, I think we will use this throughout my talk, but I think it's just important to be aware that she separates unifocal changes in the electroclinical syndrome and multifocal changes, and non-localizing changes. And I think depending on what your situation you're starting with, this will alter which possible methods you would use and whether stereo EEG makes sense or not. What is, I think, a very important take-home message is that not every additional test provides more clarity. If you already have 3 tests which contradict each other, are you really going to change your management because you do a 4th test which either partially overlaps or doesn't overlap at all? I think that's very unlikely. And more investigations, we know very well, does not necessarily improve outcomes. And this is from, for example, from a study where we looked at how epilepsy surgery in children changed from 2008 and to 2015 across Europe. It's nearly 2,000 surgical interventions that were looked at. And while the surgical investigation and the complexity increased, the frustrating thing is that our seizure outcome class 1, so the seizure-free patients, actually did not change over time. Does this mean that we are performing worse now than we did before? No, it just means that the complexity of our cases raises and that we haven't found a gold standard of investigation yet, which allows us to address these more complex situations. Moving on from these very broad sEEG concepts to discussing selecting the right candidates and the right targets. And I think the first thing, and this is again more a basic question, but I would like you to start with this before talking about new methods and new technologies, is understanding seizure semiology. And I really love this glossary, which was published by Shandor, because it allows you to get a great overview. So for example, here we are talking about the motor phenomenon, and for each of them, it will tell you whether this is in, like when you look at semiology, ipsilateral or contralateral, and it will give you some localization features. Even better, if you have never seen a certain seizure semiology, the same paper provides you with video links where you can go on and make sure that you interpret your patient correctly. Why am I pointing this out? This is why I brought you our first patient. What you will see throughout my talk is that I use random avatars just to show you when we are talking about a certain patient or when we switch patients as a visual cue. So this is here our Brian. And I want to use him to tell you how it is important to find the right target and understand semiology to find the right target. So he was 3 years old when he started his epilepsy. Before that, he had normal development, and except for a non-functional left kidney. And he started having day and night seizures with a moan, an intense fear, severe stomach pains, followed by hypermotor movements. And his awareness was preserved during the complete seizure. He had a high seizure frequency of 4 to 10 per day and showed some temporary relief of seizures with levetiracetam and oxcarbamazepine. His EEG showed bilateral frontal-central region discharges, really low amplitude, and his MRI was considered normal. We then saw him again a couple of years later, and he now had developed what I would call a constant anxiety disorder, about night and sleep. He didn't want to go to sleep. He was constantly talking about belly aches, and he still had the severe episodes of pain with sudden onsets where he said, "Ghosts are eating my stomach." We then repeated his MRI, and there was a suspicious lesion that you can see highlighted here in the anterior insular. And the scalp EEG was still very unhelpful. You see some little sharps here throughout the monitoring. And he had 15 events with arousal out of sleep with severe pain, which didn't have any EEG correlate. You can take a second here to gather your attention and think about whether you think this patient still has seizures and whether you have an idea where this might be coming from. And then we talk about the approach I earlier said. Where do I think the seizures are coming from? So for me, he has a query lesion in the anterior insular, and he has seizures in general with pain, which are in agreement with an insular onset. But what I don't know is, I think he has likely a deep focus, but the borders of this lesion are unclear. It's not even 100% of a confirmed MRI lesion. And when we talk about ictal pain, my first thought is rather the posterior insular, so behind this lesion, than the anterior insular. And last but not least, what was my aim for the investigation? Verify that the lesion is the seizure onset, define the border of these lesions, reduce the resection size, and most particular, find out whether I can spare the posterior insular, because that's a difficult surgical target with a lot of complications. The red flags for me, and this is why I wouldn't say I go right away into resection, is that the lesion did not meet MRI criteria, that the scalp EEG was normal during the events, and that I couldn't delineate the borders of the lesion. So this is the stereo EEG that we did. For you, important are these contacts here in the anterior insular, which are the ones which are going to be most active. But as you can see, we also employed the temporal lobe and the posterior insular here. And this is his interictal, which is actually nice because you now see relatively constant spiking over the anterior insular. So that is nice and confirms that we might be in our lesion there. And then we saw a seizure which reflected his pain-only episodes. And as you can see, when that happens, the events are actually really short and moving on here, and they are not spreading beyond the anterior insula. And I think that explains why we cannot see anything on the scalp EEG. In contrast, when he has a seizure with pain, anxiety, and moaning, we saw a similar seizure onset, but it then spread to the posterior insula and also some temporal regions, and the seizures were much longer, which then allowed us to see them on scalp EEG. Long story short, what did we do? He received the lid ablation of his supposed focal cortical dysplasia. He has been seizure-free since and stopped his medication 12 months ago. He stopped having anxiety and belly aches, also the permanent one, because I think that was a psychological reaction to the severe pains he had experienced during the night. He still has some symptoms of ADHD, but he does not struggle with school performance or tiredness anymore. Why did I show you this example? Because I think it's an example, even if this patient would have been MRI negative, where we could have thought about the insula. Maybe we wouldn't have had such a clear lateralization idea, but we could have thought about it. But when we talk about acute pain, and that's important to understand, this is actually more towards the posterior insula. This is pictures from a review that looks at stimulation responses, so electrical stimulation in the insula. And what you can see here is that the more red contacts are the ones which are more posterior, and the more blue contacts are the ones more anterior. And you can see that when we talk about a pain response, that the more posterior areas of the insula were clearly associated with pain, while the anterior parts were not. And if we talk about his pain, which was specific to the belly, unfortunately, and we look at this old Penfield slide, there's actually no clear representation of this, and there might be some body sensation, which is a little bit more here, but there's no belly representation or stomach representation in this chart. So for our patient, we really didn't know in which part of the insula the seizures might start. And whenever you have a situation like this, you have to be acutely aware that this insula has different areas, and that there's a very fast propagation pattern between the insular areas. So you are forced to place electrodes in all of the different lobes of the insula to actually get a good outcome. And of course, the insula is difficult because it mimics other epilepsy syndromes through fast propagation. So it can mimic frontal lobe seizures or temporal lobe seizures. And when you have to always think about the insula when you either have pain, you have constrictive sensations in the pharyngeal or retrosternal areas, or when you have vegetative symptoms. The other brain area that I want to highlight, where we often have a mislocalization of symptoms and have to be very careful and aware of, is actually the posterior cortex epilepsies. This is the summary that I wrote a couple of years ago. And what was most striking to me is that both the scalp EEG as well as the stereo EEG has a very high likelihood to mislocalize. And for example, in children's, only 40% are able to report visual symptoms or any kind of occipital lobe symptoms in the context of a posterior lobe epilepsy. So insular and posterior cortex are probably the ones where you have to be most careful when you define your targets. Moving on to identifying the right patients, I'm going to present you with Jonathan, who's 4 years old. He has autism spectrum disorders. He had his first generalized tonic-clonic seizure when he was 2 years old, and he only has a seizure every 4 to 6 months. There was never any localization symptoms, and he failed Keppra, clobazam, and valproate, both because of a treatment response, but also because he developed severe sensory problems and eating challenges with the anti-seizure medications, which is why the family gave up on each of them. What we saw on his scalp EEG is that over the posterior right brain region, he has basically continuous spike wave activity at over 95%. And we then also had an MRI, and I think it's no question that you can see this occipital lobe MRI lesion very well here. So again, do we want to do a stereo EEG in this patient? And can we help him in any way? Where do I think the seizures come from? Probably from the occipital lobe lesion, even if I have no semiology information from this kiddo. Where else could it be? It could be anterior to the lesion. Maybe the lesion we see on the MRI is only the tip of the iceberg, and we don't really know where the border of this lesion is. But I told you, for every decision for me to make to place an sEEG, I always ask 3 questions. And when we come to the last question, is whether I have a defined aim, I answered this, or our surgical conference answered this as no for the stereo EEG. We believe that the resection size is unlikely to change. He has very rare seizures, so it will be hard to record the seizures in the stereo EEG session. And he has basically constant spikes already on scalp EEG. So it's very likely that his intraictal is more widespread than the seizure onset zone. So in this kid, We have rare seizures. The main intervention is for his spike waves. We have an unclear semiology, but we have a clearly defined lesion. So we actually decided, when all treatment attempts failed and he had reported a stagnation in learning and regression, to go ahead with a lesionectomy. He has had an EEG 3 months post-surgery, which was completely normalized, and he's now seizure-free for 12 months. He hasn't had medications before, and he still doesn't have it. The most exciting to me is that he has a significant improvement in speech and interactions since he got rid of his ESES or SWOS. I present you this case because I think when we have a technology like stereo EEG, we tend to want to verify and clarify every single time. And this is just a case where I felt we could move ahead and not use the sEEG. And this is also what Dr. Zielmans did in her overview. I want to highlight to you, when we have a single lesion or when we have multiple lesions, but one lesion clearly fits with the electroclinical syndrome, then we can move ahead with a resection or a laser ablation without doing a stereo EEG. And the same can even be the case if you have a multifocal or non-localizing electroclinical system syndrome, but you have one congruent lesion, which is congruent with all the non-invasive investigations, then we would also recommend a resection right away without necessarily doing a stereo EEG. So now we come a little bit more to what we can do to actually use new methods in stereo EEG. And the first thing I want to discuss with you is, are the electrodes in the right spots? So now you've moved on, you have your implantation, and you want to know whether you're right or wrong. And when we come back to the concept, the biggest challenge about this is really that our gold standards, which are often perceived as the seizure onset zone, are performing really poorly. And when I'm talking about poor performance, I prefer to cite my own work than pointing fingers at others. And this is from the study where we looked at high-frequency oscillations and how they perform. But a sub-result of this multi-center study was to look whether the removal of the seizure onset zone, as defined by the epileptologist, predicts whether the patient is doing well or not. And as you can see here, there was no significant difference between patients who had their complete seizure onset zone removed and those who didn't in the centers which participated in the study. So our definition of the seizure onset and identifying the seizure onset can be really challenging. And I think the best way to answer why this might be the case is to look at intracranial seizure onset patterns. So this is a publication from Montreal where Piero Perrucca identified 7 distinct seizure onset patterns in their patients. And what he found is that 4 out of these 7 were seen both in the seizure onset and in spread areas. And this is what he shows here. So we have low voltage fast activity in the region of spread, as well as in the region of seizure onset delineated in orange. And what you can imagine is that if you would not have electrodes in the orange region, like I show you here, you would probably expect that this low voltage fast activity you see now in blue is the seizure onset. So you're oblivious to that you actually missed the seizure onset by not having electrode in it. So this comes back to the very early discussion in the beginnings and trying to ensure that you have all the possible targets and being aware that we have a sampling issue when we come to stereo EEG. There's also been a nice review study led by the group of Birgit Frauscher. She looked at 22 studies which looked at seizure onset patterns. First, she found that there is a significant variability on how we call seizure onset patterns. And then she also found that the only seizure onset pattern which is actually correlated with seizure outcome when you remove these seizure onset zones is low voltage fast activity, but even then it is not predictive in an individual patient for seizure outcome. So the question is, do we know when we are in the seizure onset zone? And I think often we don't because of our sampling bias. Can we then use something else to figure out whether we are in there? And one of the approaches that has been used in EEG have been various types of electrical stimulation. And again, this is from a review paper, and they looked at different types of stimulation. Down here, for example, you see 1 Hertz single pulse stimulation, and they could show that delayed responses and their amplitude is 2 single pulse stimulation is different in the presumed seizure onset zone than outside. And if you look whether this predicts seizure outcome, you can see here that the area under the curve is not too bad. But of course, we are talking about a group study, not an individual prediction, but single pulse stimulation may give you an additional hint on whether you're actually in the seizure onset zone. The other thing that you can do is, of course, try to provoke with stimulation a typical seizure. If you actually are able to generate atypical seizure in your stimulation, this is correlated with a better post-surgical seizure outcome, because I think your target electrode is more likely to be in the actual seizure onset zone. But the problem is that if you don't elicit a seizure, that doesn't predict that your patient is not seizure-free. It might just be that your stimulation parameters were not right to cause a seizure, or the patient was in an inhibitory phase maybe. And there's also very conflicting results about which stimulation technique to use to provoke seizures and which is the most reliable. This is from a survey which looked at different centers and how they provoke seizures in their stereo EEG. And the take-home message for me from this survey was that the parameters that I used vary considerably, and for example, the currents and the amplitudes are largely different from center to center, and there's not one way how we use stimulation at this point. We also just finalized a study across all the Canadian pediatric epilepsy centers, asking them how they do stimulation. And you don't have to dig into this stimulation table here. This paper will be published soon. But I think what I wanted to highlight is that all the graphs here, which are orange, are actually those areas where we as centers disagree on how we do stimulation. And in pediatrics, there is even less data than in adults on how reliable stimulation of seizures is to predict seizure outcome. I think what is another exciting way to define whether you are in the right target, and this is a complete switch of topic now, we've talked about stimulation and now we are going into genetic confirmation, is that there is a trend across several groups, and there's groups in Europe, Australia, and also one in Calgary. And of course, I'm showing you the Calgary data, which has shown that you can take DNA from an implanted electrode. So this is like finding the little surviving cells which automatically stuck to the electrode. You can amplify it, and then you can do genetic analysis from these tiny cells. And this is where we come back to our case number 1. I promised you that the avatars will show up whenever I talk about them, because this patient is particularly exciting to me because we had the suspicion of a lesion in the anterior insula, but we actually could find, and this is what you can see here, a novel variant of a mutation in the mTOR pathway in exactly the electrodes which defined the seizure onset zone. And they were not present, as you can see here, in all the other areas of where we had electrodes and cells were found. So this is a very focal lesion-related genetic change that was found by looking at cells which accidentally got stuck on the electrodes. And I think this is a very nice way of confirming that we are in the right spot with our stereo EEG. Last but not least, we can also be a bit more aggressive and just try to kill the area of the presumed seizure onset zone and see whether it changes our epileptic networks. This has been something done a lot in Europe in the past, and it's now started in North America as well, where we do radio frequency thermocoagulation. Basically, we put heat through the electrode to burn away the areas of the presumed seizure onset zone. And when we do that, as you can see here, we have the intra-ictal EEG and the ictal EEG prior to the thermocoagulation. And then you have the post recording. You can see that the epileptic activity stops. And ideally, that can predict whether the patient is going to continue seizing afterwards or not. It's a very elegant method because usually after our surgical interventions, we never can continue recording EEGs afterwards, while this method actually gives us a pre and a post recording. So question whether burning the seizure onset zone will result in seizure freedom. And this is where I come to my favorite oscillations for the first time, the high frequency oscillations. So there has been some data that shows that if you burn the seizure onset zone with thermocoagulation and your spike and ripple rates and fast ripple rates, so the HFOs go down afterwards, your patient is more likely to be seizure free. We also did some of this work in my lab led by Dr. Lachner. And basically what we could see is this is the patients with the good outcome after RFCT. This is the patients with the bad outcome. And you can see that not only the region that is immediately burned, because of course you can say, well, that's bad tissue, so you don't expect activity anymore, but also regions that were functionally collected, as you can see here across the brain, needed to show a decrease in HFOs and spike biomarkers to predict a bad outcome after RFCT. And this is what you can see here. The green areas are those where we saw a significant difference between a good and bad outcome. And you can see here that this is mostly the case in those functionally connected areas. In them, actually, the HFOs have to go down and the spikes have to go down for the patient to have a positive intervention after RFCT. Moving on to the last topic of my talk, which is also going, as you can see, I highlighted two colors here. And the reason is that I think we cannot answer one question without the other. So making sure that we understand the extent of the epileptogenic area will always be limited by the sampling limitations that sEEG comes with. And again, when we look at this graph here from Mike Zielmans, which you have seen before, ideally, when we talk about whether we have captured the whole epileptogenic area, we want to make sure that our hypothesis is right and we don't miss any areas by using all the non-invasive tools we have before going into sEEG. And this is actually a very new publication which looked at multimodal modality imaging in the surgical treatment for children with non-lesional epilepsy. And I think for me, the take-home message is that despite all of these tests, PET, SPECT, MEG, intraoperative EEG, only 50% of these patients were seizure-free. And it is often, I think it's too much to ask from the sEEG to define those people who are going to do poorly. It is also depending on whether we have the right candidates for sEEGs, and we have to be aware of the red flags and the prognosis of the patients before we move on. Anyway, when we decide to move on and we want to look at the extent of the epileptic network, high frequency oscillations, which are the core of my research, are an important part. For those of you who don't know exactly what I'm talking about, there are small oscillations in a high frequency band between 80 and 500 hertz. In my data, I mostly don't separate between ripples and fast ripples anymore, so I would say just call them HFOs. We know that there's no clear separation in frequency bands between ripples and fast ripples by now. And we know that they are variable. They can occur with epileptic spikes. They change with sleep stages, and they occur over certain brain areas with higher dominance than with others. If we talk about the epileptic network and whether they can define an epileptogenic zone, the first studies that we did was looking at whether high frequency oscillations are mainly in the seizure onset zone. But we already learned that the seizure onset zone is not worth much. So I'm going to focus on the studies which actually looked at whether removal of HFOs results in better seizure outcome. So our hypothesis would be if I remove all HFO regions, I'm supposed to be seizure-free. If I only remove them partially, I'm not supposed to be seizure-free. And then, of course, we can have retrospective data here on the group level. We can have prospective data on the group level. And we can have individual prospective data. And best, we can have a randomized controlled trial. So where are we at when we talk with HFOs? We did look at the retrospective data, and there's millions of studies of this, and this is just one example. This is an older meta-analysis that we did on the retrospective group data, and as you can see, for ripples and fast ripples, the prediction for poor surgical outcome or good surgical outcome is there's a difference from 0, but it's not very strong. So the data that we then did, where we wanted to look at prospective data, so this is like I put an sEEG in, I look at my HFOs, and I want to say if I remove this region, is the patient either going to be seizure-free or is he going to continue to have seizures? When we look at this in a group level, then we can see that there is a statistic significance if we pool them all together. But is this really relevant? Because it just means that in a group of 50 patients, HFOs are more closely linked to those patients which do well than those patients who don't do well when I remove them. I think so. We are now talking about this level here, but what I actually want to go to is down here, the randomized control data. So the first thing I have to do is move forward to the individual level. And what we saw there is that we have patients where the HFOs were clearly not all removed, because you can see it here in red, and the resection was much smaller, and they still had an angle outcome 1. So we didn't have a prediction on the individual level, and there was a parallel similar study from another group at the same time. So what I did here is correlate all the results of the 2 studies for you. And the red numbers are the ones where our hypothesis did not work out. So these patients are where we have a complete removal of HFOs, but they're not seizure-free. And these patients are where I have an incomplete removal of HFOs and they are seizure-free. 27% in total had a wrong prediction. And in 14 patients, we would have had more resection than necessary if we would have used HFOs to tailor our resection. Now, when we talk about these 6 up here, we, of course, come back to spatial sampling again. It might very well be that we completely removed all HFOs in the areas where we had electrodes, but this doesn't mean that beyond the electrodes, there are not other HFO areas. But, of course, I told you the golden grail of evidence is with clinical trials, and this is actually a prospective randomized trial where they tried to prove in using ECOG and tailoring the ECOG resection either using HFOs or spikes, that HFOs were not worse in performing to predict the surgical outcome than spikes did. So this is what's called a non-inferiority trial. And what they found is that if they had HFO as a guidance, 67% were seizure-free, and if they used spike, 90% were seizure-free. So HFOs were not inferior, so they actually performed worse than spikes when trying in this randomized trial, trying to figure out whether we could use them to improve seizure outcome. Of course, like with every single trial, we can find reasons for this. And in this case, it was a bit of a pity because they found that there was actually a significant difference in the spike group versus the HFO groups when it came to poor prognosis pathology. So when they actually corrected for that, they could show that for the temporal lobe patients, it actually worked to use HFOs and they were not inferior, while for the other patients, it did not work. So this is like, I would say, a partial negative result for this trial. And what are possible reasons for this? I think one of them is that we had physiological and pathological HFOs mixed, that HFO propagation might lead to unclear results, and that, of course, we have this black box. The first two things might explain these 14 patients here, so those where we had incomplete removal and still seizure freedom. The black box might explain these patients up here. And of course, you can imagine if I would have red rectangles everywhere outside the brain where I don't have an electrode, this can definitely explain why a patient with a complete resection might not be seizure-free. So this is where I want to move on to the last topic of my talk, which is overcome sampling limitations and the black box. And the exciting news is that we can see HFOs on the scalp. We know that around 0.01% of all cortical HFOs are visible on the scalp from looking at simultaneous scalp and intracranial recordings. Cortical HFOs are very focal in appearance, and often several cortical HFOs contribute to one scalp event. This is what you can see here from the data from our simultaneous images. So when we talk about whether scalp HFOs and simultaneous scalp recordings might help us with the prediction of outcome, one of the things that is important is to understand that we need a high sampling on the scalp EEG. So this study showed that we have significant higher rates of scalp HFOs when we use high density EEG compared to normal EEG. And then what we could also find in one of our studies is that the difference between the seizure-free and the non-seizure-free patients when we looked at scalp EEG was that we often found the scalp EEG allowed us to find contralateral, for example, HFOs, which we would not have been able to see with our intracranial EEG, of course, because we don't have electrodes there, and which then allowed us to predict poor outcome. And you can see that here. If we look at the patients with good outcome on the left versus poor outcome on the right, the average number of channels was significantly higher. That showed HFOs on the scalp was significantly higher in those with a poor outcome. So what can we do to overcome the black box by looking at beyond the stereo EEG? That is the publication that just came out last year in Journal of Clinical Neurophysiology, where we tried to explore this concept. And we looked at 3 simultaneous recording options: fMRI and sEEG, MEG and sEEG, and scalp EEG and sEEG, all of them recorded simultaneously. I'm going to give you just a little bit of a hint, and you can read more about it if you want, about what is intracranial simultaneous intracranial EEG and fMRI. So this is where the patient had, we looked at HFOs and intracranial discharges in the stereo EEG during an MRI recording, and then we looked at the responsive bold responses. And one of the conclusions was that whenever we see a very widespread or very distant bold response, that is actually poor for the surgical outcome. And this is hot off the press, Brain 2024, one of the studies from the people in Calgary who look at simultaneous intracranial and EEG and fMRI, and they could clearly show that if you have a low, if your board response is far away from your electrodes, then you have a low confidence that the patient is going to have a good seizure outcome, while if we have a good overlap and all the bold responses are close to your contact, then you have a much higher confidence for seizure outcome. There is a lot of literature on simultaneous scalp EEG and sEEG, and I just want to conclude my talk by giving you a very short case, which I think illustrates why I really like my patients to have simultaneous scalp recordings. So this is our last patient today. He had an epilepsy onset at age 5. The seizures have a loss of context, oral and manual automatism, and sometimes secondary generalization. So they have a very temporal lobe flare. He failed several medications. His EEG was bilateral interictally, but all seizures we recorded in the long-term monitoring unit were from the right temporal. His MRI was normal, and he actually had a PET scan which showed, I don't know why this is lost here, a PET scan which showed a very wide hypometabolism over the right temporal and parietal regions. There is the PET. Obviously, there was just something different with my showing up. So widespread temporal and parietal hypometabolism. So what, again, are our hypotheses? I think this might be from right mesiotemporal, from how the seizures are showing, but it could be also right neocortical temporal, and the areas of the PET changes were much more widespread than just the medial regions. So we decided to implant him with an extensive right temporal, neocortical, and parietal implantation to verify the seizure onset over mesiotemporal and delineate the resection areas. There might have been some red flags, some of them is the non-lesional MRI, the widespread PET, and the bilateral interictal EEG. So what did we see? You can see here, and unfortunately it's a little bit small, but these are the right temporal regions. This is actually temporal neocortical here, where you see all the spikes. And his seizure onset, where we saw it on the stereo EEG, was here over the right and then evolved from here. This is all you would have seen if you wouldn't have had scalp EEG. I also hid another fact from you. The clinical onset of the seizure was clearly prior to this discharge. And we then could see actually the seizure evolving here over left temporal prior to occurring on right temporal. Note, we didn't have any left temporal seizures on the scalp EEG, but of course we know that there's also a time sampling bias to long-term EEG monitoring. So 2 of his 7 seizures had this onset pattern, and I think it's a good example on how a scalp EEG can help us to overcome the black box. What are my conclusions? It is most important to decide where you place your electrodes from all of our 3 cases here. Our gold standards are far from perfect. Some methods can indirectly show whether you are in the right place, like stimulation, thermocoagulation, genetic analysis. Finding all seizure-generating areas will always be limited to your undersampling that you automatically have with your stereo EEG. New biomarkers are likely to raise a red flag, but not solve everything. And last but not least, simultaneous recordings might reduce your black box that you have with the undersampling. And with this, I'd like to thank my team, my funders, and you for your attention.
Great. Thank you so much, Dr. Jacobs. That was really insightful into understanding some of the qualifying questions for candidates and just some of the complications with identifying the seizure onset zones. And we have a few questions for you before you have to head out. Again, we really appreciate your time this morning. We have a question from Mr. Sachin. How different are HFOs and sleep activity in the sEEG? Like sleep spindles.
Oh, okay. So I think when we talk, so I think we usually would, of course, assume that high frequency, or there are two types of high frequency oscillations, those which we presume to be physiological, for example, in the hippocampus, the sharp wave ripples, and then those which we presume to be epileptic. And when we talk about epileptic HFOs, we know that they are modulated by sleep stages. So, for example, they are more frequent in non-REM sleep than in REM sleep. And also we have used sleep staging and looking at separations of REM sleep, for example, between tonic and atonic sleep, to understand which of the HFOs might be more physiological and more epileptic. So there is I would say the two HFOs are dependent on sleep. They change with sleep, and epileptic HFOs might have a different response to sleep than physiological HFOs. I think if you see a lot of nice HFOs coupled with sleep spindles, for example, we are quite certain that these are not epileptic and you don't have to remove them to have a patient to be seizure-free.
Great, thank you. We also have a question. Would you recommend spike gamma activity as a reliable biomarker for the indication of the seizure onset zone?
So I think there has been some data which shows that both a spike gamma, like the high frequency component of the spike, so spike gamma or spike high frequency oscillations, might be more reliable than looking at the spike itself. And I think there might be two reasons for it. One of them is that we have less fast activity on a spike whenever the spike is more a propagation phenomenon, so not so close to the source. And that for that it can be helpful. The other part is that there is this old concept of Rasmussen, which tries to separate more evil and less evil spikes in red and green spikes. And of course, I'm a bit biased because I work with HFOs, but I think looking at gamma activity during spikes or HFOs during spikes will help you to select the more evil spikes of the irritative zone, which might need to be removed.
Thank you. And then our final question, and this is something that we can follow up if we don't have time to answer it. We have about 1 minute left. Recording parameters for sEEG that are most helpful for identifying HFOs.
That is actually a relatively easy question to answer because so that we have no evidence that there are certain electrodes which work or don't work for HFOs. So you can basically use every commercially available electrode. And nowadays you can also use, I would say, 80 to 90% of the commercially available amplifiers. Your most important criteria are that you have a good signal to noise ratio, and this might even vary with the amplifier depending on your hospital setting, and you have to check for this. And then even more important that you have enough sampling rate. So when you install your amplifier, make sure you use the maximum sampling rate it offers. And for HFOs, the minimum, if you want to look at ripple, would be around 1,000 hertz. And ideally, you would be at 2,000 hertz and above with your sampling rate.
Excellent, thank you. All right, well, that is the end of our time this morning or evening, depending on where you are. Thank you so much for joining us, Dr. Jacobs. We really appreciate your time and your valuable expertise on the intracranial and sEEG. We will be following up on our website with more information about this Persyst Grand Rounds. Thank you, Dr. Jacobs.
Well, thank you very much for having me. And you saw my contact at the end. If anyone has a question, you feel free to reach out. And I hope you had a good time and learned something.
Thank you. All right. Bye-bye.